At any rate, welcome everyone. My name is Kenny Mendez. I'm the president and CEO of the Asthma and Allergy Foundation of America. I'm also the current NHC board chair. And on behalf of the board, welcome to today's events. It's great to see everyone. And before I turn it over to Randy, I just want to make a quick pitch for the NHC. You know, I don't think you're going to find an organization like us in this area that brings together patient organizations, and our mission is to amplify the patient voice and other stakeholders in the healthcare ecosystem under one roof. So there's a membership table or registration. You could ask about membership back there, but really appreciate seeing everyone here. And hopefully today's event you'll see is exactly what the NHC does, bringing together diverse stakeholders, amplifying the patient voice, and bring in terrific speakers that you could learn from. So with that, I'm going to turn it over to NHC's President and CEO, Randy Ruda. Thank you.
Good morning, everyone, and thank you, Kenny, for your inspiring opening, our kickoff to an exciting day, and for your leadership at the National Health Council and a strong patient group organization. And thank you all for coming together today on this really crucial discussion, the science of patient engagement and digital health. I'm Randy Ruda, the CEO of the National Health Council, and I truly believe that equal access to high-quality, affordable health care is a priority for every American. Especially true for the constituency that we represented so well here in the room, 160 million Americans with chronic conditions and disabilities. Today's symposium affirms the importance of patient centricity and in the healthcare system and putting patients first, which is our tagline, and I would say in this context is really a call to action. You know, from clinical research, diagnosis, treatment, and discharge, the growing role of life-saving digital and technology innovations are fueling hope and help for patients, their families, and stakeholders. Optimizing the full value and impact of digital and artificial applications requires active engagement of patients at every step. We must listen and compassionately deploy new technologies consistent with core patient priorities concerning equity, dignity, and privacy. This is what today's symposium is all about, inviting strategic insights from leaders, experts, and advocates to assure our collective understanding and progress on all fronts of a very promising and dynamic digital transformation for, with, and benefiting patients. As we get started, I want to thank the distinguished chairs and committee members of our Research and Program Committee for their strategic direction in planning today's event. Dr. Ovid Amate and Leah Howard, who you'll hear from in a minute, serve as co-chairs, and then our committee members, Irene Anye, Dr. Irene Anye, Cynthia Benz, Andrea Ferris, Dr. Devin Jopp, Louise Vetter, and Dr. Jill Yursak. And a big thank you to our sponsors for their support for this symposium. We could not have developed such a robust and timely event without their generosity and support. Nero Biosciences, Merck, Sandoz, Eli Lilly, and Servier Pharmaceuticals all provided support for us to come together here today on this topic. And lastly, I'm pleased to acknowledge the National Health Council Research and Program staff, who have done an incredible job in planning this event and coordinating an amazing series of speakers to explore critical topics on digital health and the science of patient engagement. And they are Dr. Omar Escontrias, Silke Schock, Lillian Wittig, and Karen Manceras-Cuevos. So let me say it's with sincere gratitude that all of the National Health Council is engaged in today's discussion. I look forward to speaking with you throughout today and at the reception at 4:30 tonight, where Omar assures me there'll be more discussion, great food, and a lot of networking opportunities. So with that, let me call on Dr. Omar Escontrias, the National Health Council's Senior Vice President of Equity, Research, and Programs, to discuss our agenda and keep us going. Thank you, Omar. Thank you all.
Well, good morning, everyone, and thank you, Randy. I would like to begin by acknowledging the ancestral lands of which we stand first. Every community owes its existence and vitality to generations from around the world who contributed their hopes, dreams, energy, and making the history that led to this moment. Some brought here against their will, drawn to leave their distant homes in hope of a better life, and some have lived in this land more generations that can be counted. Truth and acknowledging of a critical in building mutual respect and connection across all barriers and heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We stand on the ancestral lands of the Nakachtung and the Pistagoat people. We pay respects to those elders past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and the settlement that brought us here together. So, thank you again. I'd like to spend a moment addressing the significance and importance of the 2023 Symposium's theme, Patient Empowerment in the Digital Health Era. We all know that the COVID-19 pandemic brought a new perspective and urgency to understanding and incorporating the patient voice in digital health. No research should be accomplished without the consent, perspectives, and comprehensions of the patients and family caregivers it is meant to serve. Let me repeat that, who is meant to serve. This should also include the voices of historically underrepresented groups in research, including the differences by sex, gender, sexual orientation, racial and ethnic background, geography, different countries and languages of origins, disability, and health status. Digital health is a very broad concept. However, our definition takes a two-pronged approach to look at both the technological and accessibility aspects. This includes mobile applications, artificial intelligence, medical devices, assistive technology, machine learning, and more. Throughout the symposium today, we have a couple of objectives: to understand the applicability of patient engagement research into action and practice in the digital age, illustrate the importance of health equity integration into patient engagement research, identify synergistic research opportunities between scientists and patient advocacy groups, and also exchange innovative and thought-provoking research ideas and agendas. Now on to some housekeeping items. Please, as a respect and delivery for the content of our speakers, take the time to silence your phones and our other electronic devices at this moment. Restrooms are located at the end of the hallway to the right outside of this room. All the breaks and lunch will be available in the foyer, which is where you walked into registration. And this evening's reception will be held at the Home and Lounge, which is located next door in the room to the right. As a reminder, please use the elevators you used to enter this event near the front of the building. The elevators you saw in the breakfast station only take you down, but not up. Complimentary Wi-Fi is available for our event. All Wi-Fi instructions are located on your tables. You're also welcome to live tweet this event. Please use hashtag SPES 2023 or hashtag putting patients first on all social media posts. We have multiple members of the media attending this event. They are identified by a black ribbon on their name badge. Very importantly, we have placed also evaluation QR codes on each of your tables, so at the end of the day or before you leave, please complete the evaluations at the end of the day. Your feedback is extremely valuable to the NHC and its plans for future events. We will kick off with our keynote speaker, the FDA Commissioner, Dr. Robert Califf. Over the course of the day, we will also have 6 sessions with 10-minute breaks between them where refreshments will be available in the foyer. As Randy and Kenny mentioned, the reception will be this evening from 4:30 to 6, and after the end of the program. We hope that you will have a wonderful and engaging networking with your colleagues and perhaps some new faces. So please, hope you have your business cards ready to go. Lastly, I would like to acknowledge our patient groups and NHC members in the room. Your research, advocacy, and patient-centered initiatives are admirable, and the NHC thanks you for your passion and dedication. Our dedication to patient-centeredness is more critical than ever, and for the first time, all sessions of this symposium are moderated by patients or patients advocates from all walks of life and experiences. We also thank them for all what they do, so please help me give them a round of applause for all their work. And now it is my pleasure to turn it over to Leah Howard, the co-chair of the NHC Research and Programs Committee and member of the NHC Board of Directors, to introduce our keynote speaker. Thank you, everyone.
Thank you for the wonderful introduction, Omar. My name is Leah Howard, and I am the President and CEO of the National Psoriasis Foundation. And I am so excited to be here at the 2023 Science of Patient Engagement Symposium. The topic of this meeting is very exciting and important. At a time when healthcare innovation is advancing at such a rapid pace, it is imperative that we guarantee patients a voice in their own healthcare. The National Health Council provides leadership in protecting patient rights, and today's event helped establish a blueprint for the future when it comes to how we interact with the patients fairly, equitably, and ethically. I am honored to introduce Dr. Robert Califf, the 25th Commissioner of the Food and Drug Administration. As Commissioner, Dr. Califf oversees the full breadth of the FDA portfolio and execution of the Federal Food, Drug, and Cosmetic Act and other applicable laws. This includes assuring the safety, effectiveness, and security of human and veterinary drugs, vaccines, and other biological products for human use and medical devices, the safety and security of our nation's food supply, cosmetics, dietary supplements, products that give off electronic radiation, and the regulation of tobacco products. Dr. Califf has had a long and distinguished career as a physician, researcher, and leader in the fields of science and medicine. He is a nationally recognized expert in cardiovascular medicine, health outcomes research, healthcare quality, and clinical research, and as a leader in the growing field of translational research, which is key to ensuring that advances in science translate into medical care. We are very excited to have Dr. Robert Califf join us today. Please welcome the Commissioner. Thank you so much.
Thanks for that kind introduction. If I seem a little sluggish today, I spent the weekend at a Southern Baptist funeral in my hometown of Columbia, South Carolina. In that faith, it's not a bad thing. My uncle died at age 90. He had a great life, and as I heard said many times at the funeral, he's going on to greater things, meeting old friends that he's known for a long time. But what happened to me was, after I ate the fried chicken, the broccoli casserole, the corn pudding, what was served up for dessert was chocolate pound cake, coconut cake, and banana pudding all on one table. So my great act of holding back was I didn't eat the banana pudding, but everything else I had a taste. So I am delighted to be with you. This is, I think a lot of you know, this is like my favorite topic, so it's sort of killing me that I'm not going to be here for the whole meeting because you're covering a lot of really important topics at the intersection of patient engagement and digital health. These are both priorities at the FDA. And as I've said, these are areas in which I've done a lot of personal work. And the program, as I look through it, I think you hit the nail on the head to look at the intersection of these areas because they're synergistic, not independent of each other. And as the digital world and understanding of how to engage with people converges in many ways, this convergence gives tremendous opportunity, but also raises a number of really serious questions about our approach to clinical research, health, and healthcare. Your agenda includes an exciting set of what I call red-hot key topics in the area. So what I'd like to do is make some general opening comments and then take questions and have a discussion as you move into the rest of the agenda. I'll start with the concept of patient engagement. We're lucky to be living and working in a time of unprecedented scientific, medical, and technological breakthroughs. We have a deepening understanding of the underlying mechanism of disease, human biology, genetics, and genomics, and of the enormous opportunities afforded through the development and application of new technologies, including the expanded ability to digitally collect, review, and share data. These technological advances allow us to envision, explore, and realize unprecedented new approaches for preventing and treating a wider range of previously untreatable diseases. The key is that we need to do this together. In combination with these more biologically and mechanistically oriented scientific advances, we also are breaking new ground in understanding human behavior, social interactions, and how they're inextricably intertwined with health, disease, and human outcomes. As in many fields experiencing a rapid growth in technology and knowledge, uncomfortable questions are raised that will test our mettle as we delve into an exciting area with so much potential and also with so much risk. One of the most important aspects of our work at the FDA is to incorporate the perspectives and experiences of patients to make sure the evidence reflects what matters most to and is most effective for patients and their caregivers. It seems obvious to say that if we want essential insights about what it's like to live with a disease, the outcomes that matter, and the adequacy of treatment options, we should ask people who are living with the problem or at risk of experiencing the problem, both patients and carers or caregivers. As we focus in on the issue, especially with improved digital technology, we should be able to design a more accurate, more complete benefit-risk framework that helps us better evaluate the safety and the effectiveness of a medical product across the vast expanse of patients and consumers who may have different values, educational levels, living and healthcare environments. We need to assure that the experience of living with a disease is factored explicitly into the development programs for all medical products, including measures of benefit and harms within clinical trials. We're also entering a new era of ability to assess and improve the fit between the product and people who could benefit or be harmed from its use, otherwise known as human factors. We're getting better at this as we gain experience with explicit integration of the patient voice into our work. For example, our patient-focused drug development initiative engages patients and caregivers in a facilitated dialogue with the FDA on a variety of individual diseases to develop rigorous and objective methods that can measure patients' experiences and perspectives in a reliable and representative way. This can include the development of methods for the identification of key impacts and elements of disease experience that matter most to patients, and the translation of those elements into measurement tools that are clear, register meaningful change, and prove valid and reliable in capturing patients' reported experience in clinical trials and clinical outcome studies. Our patient representative program brings the patient voice to discussions about new and already approved drugs and devices, as well as to those that are currently being considered for approval. It also allows for input earlier in the regulatory medical product development and review process. Patient representatives can serve on FDA advisory committees as consultants for the review divisions in the determination of whether a medical product's benefits outweigh its potential risks, and as presenters at FDA meetings and workshops on disease-specific or regulatory and health policy issues. These and many other models of patient engagement are being used across the FDA and are making a real difference. But this is where the rapid advance of digital technology is likely to disrupt our current methods. We have enormous potential as the world moves to traverse the fourth industrial revolution, in which rich and diverse sources of digital data are available at scale in real time with potentially unlimited storage capacity. And these data are becoming widely available as part of the clinical care system. Large language models are the next step that appears to be ushering in the revolution that many of us were hoping for. I toiled in the clinics for 35 years, and as time went on, I spent more and more time clicking buttons and documenting instead of talking with patients. Maybe that day is coming to an end now. Throughout my career, I focused on strengthening systems for generating and gathering new and better data and analyzing those data to provide reliable evidence to inform and improve the many decisions that we make as consumers, patients, families, clinicians, and regulators. This kind of information supports the nuts and bolts of FDA's work. The ultimate goal of gathering all this data and evidence is to better inform our knowledge about the benefits and risks of health interventions and to assure that they can be used to improve health relative to the risk or harm. Of course, our focus at FDA is on medical products, nutritional interventions, and prevention of death and disability from tobacco products. But as we expand our capabilities with digital technologies, the previous bright line between the individual product and the environment, both human and technological, only makes sense in the early phase of development and assessment. Ultimately, the benefits and risks of the use of a product depend on whether and how it's used and the context in which it's used. Digital health technologies provide opportunities to foster more efficient conduct of clinical investigations by making the operating characteristics of specific digital measurements in their context of use. For instance, they can be used to remotely record and analyze data directly from participants throughout the day. It never made sense to me as a cardiologist to have someone come in every 3 months for a 6-minute walk test if you could measure how much walking they're able to do in daily life. And the use of DHTs in a clinical investigation can help improve patient access to and participation in clinical investigations by potentially reducing the burden of required visits to a research site. As many of you know, there are multiple projects underway to generate greater volumes of high-quality, relevant digital health data, including the facilitation of efficient, streamlined, randomized controlled trials and registries by extending the uses of existing digital health data. For example, one focus of our orphan products grants is to support the development of virtual or digital health platforms and models that can integrate data and serve as management or monitoring tools and inform good clinical practice. I should also point out that while the impact of these data is significant for the development of medical products and treatments, it has important applications for and supports our regulatory decisions in food safety, tobacco products, and all the products we regulate. Now the hard part. Let me identify some large questions I hope you will solve today in your discussions, because I don't know the answers to these problems. The first is disparities, which has already been, I think, very accurately referred to. We are experiencing a dramatic decline in life expectancy in the United States, only partially due to COVID, but also including gun violence, suicide, and opioid overdose. But we're talking less about another lurking problem, the ongoing rise in chronic diseases and their sequelae for problems like stroke and heart attack, something that as a cardiologist I thought we had solved 20 years ago. It's now on the resurgence. This alarming situation is not uniform in the U.S. Differences as a function of race, ethnicity, sex, education, wealth, and rural living status are stark, and many of them are actually diverging, not coming together in the way that we would hope they would. I've been unable to get a quote from Ed Young in The Atlantic out of my head since I first read it a few months ago. Technological solutions drift into society's penthouses. Diseases seep into its cracks. Think about that for a bit. In my 5 years at Alphabet, and I know you're going to hear from Alphabet later on today, the smartest people in the world, as far as I'm concerned, in terms of software engineers, would spend tremendous effort to make a product available for all people, but inevitably, the wealthy, the highly educated would make best use of the product right out of the hatch. It's a problem that, as far as I'm concerned, we have not solved. So I urge you to think beyond the hypothetical or artificial laboratory-based assessment of how new drugs, devices, and foods will be used across our society. The second is representativeness. It's obvious that we now have the ability to interact with almost the entire spectrum of people with a disease or at risk. Well, I believe, as represented so well here today, that patient focus groups, advocates, and representatives are phenomenal. We'll eventually need to address the diversity of values, preferences, beliefs, living circumstances, and economic factors by directly measuring them in broader populations, as evidenced by the ubiquity of cell phones and companies with billions of users. Our challenges and limitations are no longer technological. They're embedded in our human interactions. I would urge you to look at CDRH, which has done some fabulous work dating back to 2015 and before that, showing that the balance of benefits and risks with a device can look quite different for a product depending upon the preferences that vary across the population. That is, given exactly the same data, the benefit-risk equation may be positive for some people given their values and negative for others. The third problem is algorithmic bias, something that's talked about a lot. Algorithms, including the new large language models, evolve after they are put into practice. It's unlikely, and again I want to say this clearly, unlikely that an accurate algorithm will stay accurate when deployed in real life over time. It needs adjustment and measurement of its operating characteristics continuously throughout its life cycle. I want to give credit here again to our Center for Digital Interventions in CDRH, which is, and if you look at their diagram going back to 2014, the most important part with algorithms is not the pre-market component, it's what happens after it's put out there. How do we get that done? Because we're not doing it now. The next is large language models, otherwise known as ChatGPT in the common vernacular. If we're not nimble in the use and regulation of large language models, we'll be swept up quickly by something that we hardly understand. The great things are really great. Imagine a world in which your questions were answered immediately in language appropriate for your literacy and numeracy. Also, your clinician can actually talk with you rather than spending all their time cutting, pasting, and writing clinic notes. I could go on, but I see the regulation of large language models as critical to our future. Almost done. The next one is misinformation. Many Americans die or experience serious illness every year due to bad choices driven by false or misleading information. This trend has accelerated as social networks have driven communication based on common social identities that are ripe for exploitation. And spending time with my low-country South Carolina relatives reminded me of how different the universe of information is that they're exposed to compared to what I see every day. This new digital era can connect us, but technologies like large language models give almost everyone the potential to produce a false narrative or even so-called deep fakes, fabricated images and voices. Don't be surprised if you see images of me speaking on the internet when it's not me, but it looks like me completely and has my voice completely in it. A key part of successful transition to digital health is an effective regulatory scheme to guide digital technologies to improved human outcomes and interaction. And the last is privacy and confidentiality. It's abundantly clear, at least to me, that if we want the best treatment for ourselves, we'd better hope that others have put their data and their participation on the line, so our clinicians and we, to the extent we want to know, can have confidence about how people like us, to use a common phrase, did with the planned interventions. We've not reached the right balance on these issues, and I believe we need to have a vibrant discussion, hope some of it will happen today, about the advantage of research participation and data sharing and the reciprocal obligations of those who collect the data. Across industry, digitization and insertion of machine learning and other types of mathematical algorithms in everyday life is making a profound difference. But government agencies lag behind private industry. Quite simply, we need to assemble the resources and put in place those policies and tools and adaptively align our digital health efforts to support public health and regulatory innovation in a world that's changing rapidly. The potential certainly exists, and we have good reason to hope that we will fulfill the enormous potential of digital health technologies and see more innovative solutions that can result in improved outcomes. But we better also preempt the risks. Thank you, and I look forward to your questions.
Great. Thank you, Dr. Califf. Fascinating talk, and we obviously have a lot of work to do here today if we're going to solve all those questions by the time of the reception.
I'm counting on you.
So let me ask you, referenced COVID earlier. Digital health technologies and interest in devices and apps has surged during the COVID pandemic. How is the FDA being responsive to these fast-moving issues and making sure patient preferences and desired outcomes are prioritized?
Well, as I tried to say diplomatically, I think we're hyper-aware of the changes, and we have adapted. As you know, many more clinical trials have substituted digital measurements for what used to be in-person measurements, and we're going to continue that. A guidance on draft guidance on decentralized trials just came out, for example. But I also don't want to pretend that we're, as I said, I think we're behind, and it's going to be really hard to catch up, because particularly, I can't stress enough, and I tend to get overly excited about new things, but I actually really think that large language models are an exponential factor that we've been waiting on, but it has a life of its own that we'd better get out in front of. I'd also stress that FDA has a very important role to play, but we need you all to have a lot of discipline. Because, I'll just give the example that I gave. As a cardiologist, it just seems silly to do periodic assessments of exercise capacity. On the other hand, having spent 5 years at Alphabet, when you really grapple with the issues of missing data, artifact, we had the thing at Cleveland Clinic that I'll never forget, where, this is not an Alphabet issue, but when the activity trackers were put on employees, there was a whole business that developed of people wearing your activity tracker so you would look like you were doing more. So there's a lot to do to get this right. No one denies the potential, but we got to have discipline.
Great. So I'll ask one more question, but then we're going to open it up to your questions. So we've got a couple of microphones, so please feel free to step up to one of those. If you would share your name and the organization that you represent before you ask your question, that would be great. So you gave us some big challenges, some big questions that we should think about. Curious, you have a room full of amazing patient advocate, patient organization representatives. So let me ask the flip side to the challenges question about opportunities. As you look at the future in the next, let's say, 3 years for digital health and patient engagement, how can this audience of patient advocates help in alleviating some of these challenges?
I think the main thing is, as I said, we have to do this together. So you need to be very activated, very energized, insistent. Avoid the trap, and this is a hard one, avoid the trap of jumping to a conclusion, for example, about whether a treatment works until you've done the work to show it. I'm still impressed. The numbers remain pretty much the same at FDA. If you look at drugs that make it into phase 1, close to 90% don't make it to market because Mother Nature is just a lot more complicated and smart than we are. And 100% of those things had really smart people who thought they were going to work, investors who put tons of money into it, IRBs that approved the human studies, and an FDA that said go ahead. So I think just hardcore, making sure we get it right, but not letting people say this is the way we used to do it, so we're just going to keep doing it that way.
Great. I don't see any questions, so I'll ask one more.
I can't believe they're not.
I know, I can't either. So you talked earlier about the patient-focused drug development program and some of the other patient engagement opportunities and resources the FDA has. And many of us are familiar with the committees and listening sessions, various programs and collaborations. Do you think that this has changed industry standards in digital health, and if so, how?
Well, I think patient involvement overall has changed industry standards, but not enough yet. And I think one of the really hard things about it is that for things to really change, there are multiple components that have to change at the same time. So there may be like a group within a company that wants to make a big change in the way things are done, but you've got the regulatory consultants who are saying, wait a minute, if the FDA doesn't go along with this, you might have spent a lot of money and then at the end of the day, not get your product approved. You got other people saying, wait a minute, if you really measure things, you might show there's some problems with this product that weren't anticipated. So there's obviously a lot of opportunity, but we have to sort of get everything in sync. And I also want to stress something that I said, which I think is one of the most, to me, one of the most interesting challenges. And I think Garth Graham's going to be here later on today. I used to work with Garth in my previous job, and when you're working in a company that has 10 products with over 1 billion users a month, you really get a sense for how technologically easy it would be. For example, I'll just pick on type 2 diabetes because it's a hot area right now. You should be able to assay what the whole spectrum of people are thinking about their problems, not just representatives. I think representatives do as good a job as they can, but how can you represent 50 million people? But if we got the rules right, we could ask 50 million people, you know, how would you value these various outcomes? What's bothering you the most in your daily life? These are questions that marketeers are using every day in business, but in healthcare, we don't use them effectively.
That's right. Please.
Hi, my name is Meg Didier. I'm actually a single ventricle patient and have lung cancer circulation, and I'm very happy to see a cardiologist in your position as someone who doesn't have any treatments right now with the FDA, and so it's very fantastic. As we have been discussing, medicine is advancing, and we have a lot of great technology that is advancing these pediatric patients into adulthood. Is there anything from a data perspective that the FDA is looking at as far as helping with the transitional care period? Because a lot of data is being left off once patients have to transition into an adult center. And so is that something that the FDA is looking into?
First of all, thanks for standing up. I have a daughter with congenital heart disease myself. It's not the reason I went into cardiology. It was sort of happened after I had decided to become a cardiologist. But she's 44 now and has a daughter herself who's a freshman in college. So I'm fully aware of the wonders of technology. And I'm also very aware of what, just for those who are not in this arena, what generally happens in congenital heart disease, which is about 1% of our population, is the pediatric care is pretty well regulated and dispersed across the country. Although I'll also point out almost all the centers are in big cities or university towns, so rural people are disadvantaged. But when someone passes that year of 18 years old threshold, now you're in the adult world, and there are not enough experts to deal with it. You know, I know you can handle this because I get the sense, but you wouldn't have been alive, and my daughter would not be alive today if she had been born just a couple of years earlier. So it's a whole new group of people that didn't exist before. But this plays into one thing I was trying to say. The minute you get into digital technology, you see that what used to be a clear swim lane for the FDA, which is you got a product, you assess the risks and benefits in an experiment which is done in a research setting, and then somehow you throw that over the transom to society and say, good luck, basically. The digital sphere gives us a chance to bridge that divide. Now, it's really critical that I say we do have a swim lane. So what you described is not an FDA swim lane, but we're accountable for the safety and appropriate use of products for their entire duration. So we have a seat at the table and a say. I would just say the U.S. healthcare system, we're spending $4.3 trillion. Our life expectancy is 5 years shorter than the average of high-income countries. We're in last place in high-income countries. So whatever we're doing, we need to do something different.
Great. This will be our last question. Go ahead.
Hi there, Nicole Bashi, National Multiple Sclerosis Society. And my question is, how do we achieve authentic patient engagement with FDA, with industry, et cetera, and not just checking the boxes, not just saying, well, I contacted the National MS Society, but you didn't actually speak to a patient?
The only thing I can say is be insistent and have courage. It is my genuine experience having, you know, I'm old enough now at age 71 to say I've pretty much been around the block of all the healthcare spheres, industry, academia, healthcare systems, business, et cetera. 99% of people really want to do the right thing, but they exist in an environment where the outcomes of interest are financial profit loss statements, even in not-for-profit health systems. And so box checking becomes a fine art, just like it does in any bureaucracy. And I tell medical students this, undergraduate students, I'll say the same for patient advocates. You just have to have the courage to speak out and identify lip service where it exists. The problem is lip service is in great abundance right now. Not because people don't want to do the right thing. And if you want to read what it's like on the other side of the equation of a clinician, I would urge you to read the literature on moral injury, which is a condition where you know you're doing the wrong thing over and over, but you can't do the right thing because the conditions of your job prevent you from doing it. So, it's easy for me to say because I wake up every morning and get a list of all the people that are calling me stupid and crooked and all that stuff. But we can take it at the FDA. We're used to being criticized, so keep us on our toes. But I would urge you to look at the other players in the ecosystem. When the health system says, we're really setting up a great clinic for this or that, ask them, are they doing it for patient good or are they looking at the profit and loss statement? Obviously, you got to account for both. You can't, if you're going to lose money, you're not going to be in business. But have the courage to speak up.
Great. Thank you, Dr. Califf. Thank you for starting our day with a wonderful keynote speech.
Hello, everyone. Thank you, Dr. Califf, for that fabulous speech. We are continuing our focus on digital health. Our next session will be on bridging the digital divide, disparities in diagnosis through telehealth. My name is Beth Matthews-Bradshaw. I'm the Vice President of Research and Patient Engagement at the Alliance for Aging Research. I'm excited to introduce our speaker, Dr. Nicole Turner-Lee, Senior Fellow of Governance Studies and Director for the Center of Technology Innovation at the Brookings Institution, where she researches equitable access to technology, broadband deployment, and internet governance. Her expertise is at the intersection of race, wealth, and technology within the context of civil engagement, criminal justice, and economic development. Prior to her work at the Brookings Institution, Dr. Turner-Lee has served as Vice President of both the Multicultural Media, Telecom, and Internet Council and the Media and Technology Institute at the Joint Center for Political and Economic Studies. She has led research and initiatives to advance digital equity and inclusion for historically disadvantaged populations and has a new book coming later this year titled Digitally Invisible: How the Internet is Creating the New Underclass. After Dr. Turner-Lee's presentation, we will engage in a thoughtful conversation and open the floor to questions. Dr. Turner-Lee, the floor is yours.
All right. So we decided to be a little bit more fireside-y, especially since it's after a weekend, and to break up some of the format. I'm excited to be here for a variety of reasons. I had a very great personal invitation from Omar. We should give him a hand for just thinking about this conference. Thank you. Being together. And the whole team, the leadership and the staff at the National Health Council was very, very wonderful in their hospitality to me. Just to give you some background before I jump into the slides, I know I only look 21, but I've been working on the digital divide for 3 decades. And I've been working on it first as a person who has worked as a digital activist within local communities, and now as a researcher at the Brookings Institution. And so closing the digital divide is personal to me. And it's personal from the standpoint that technology has the ability to be an enabler, like we heard the commissioner speak about. And it also can be something that buries the identities and perspectives and experiences of people. It's no secret that today, some of you may follow this, I'm a tech wonk, that one of the most pioneering FCC chairs, Newt, passed away today. And he was one of the people that was the pioneering thought leader on the future of television and the impact on children. And I could not, in my mind, think about, he was appointed under Kennedy, how important technology and communications has been. Because if you fast forward to today, we're no longer talking about TV. We're talking about social media, and what we heard the commissioners talk about, we're talking about generative AI, which is going to have an effect as we look at the mitigation of bias. And so when I'm not talking about the digital divide, I'm talking about AI. and I'm talking about equity, and I'm talking about what we're going to speak on today, how do we get more people enrolled where they have agency over the technology, and they're not necessarily the subjects of the technology. So we thought we would just do some level setting for folks who are a little less familiar with the digital divide and telehealth, and then just some things that keep me up at night, which are a lot of things. And then we'll go into a discussion, right? So I feel like the moderator for a minute because I'm like sounding all speechy. But let me just show some slides. Okay. So I wanted to show this slide just so people understand where we are when it comes to the digital divide and Americans today. It's pretty common knowledge by the Pew Research Project that works on American internet life that folks that are primarily connected, that are people of color and people who are low income, tend to be connected by their smartphones. That has been a trend that has been an upward trajectory for the last few decades. And more importantly, it's a trend that actually mattered during COVID because a lot of folks who did not have household broadband had to rely upon their smartphones for connectivity. There were some pluses and negatives. School-age children could not write research papers on smartphones, but we did see people like my mother who were in their late 70s using a smartphone to stay in touch with her doctors. She's MDS. And so during COVID, it was very hard for her to get to her doctor. So when she soon found out how to turn the camera around so she could see him and he could see her, it worked very well for her. And we as children dispersed throughout the country were very excited about that she was actually learning telehealth. But folks who did not have that privilege, obviously, as you see in the numbers, were not able to take advantage of this. And I showed this slide in particular without getting too PowerPointish, because low income is often affiliated and associated with educational outcomes, age, and where you live, whether it's rural or it's urban geographies. So again, home broadband was high, but that lower line of 93% was represented among those who made 100,000 and more. What was interesting to me during COVID, though, is that the usage of telehealth actually increased. So I'm not going to take for granted that everyone in this room is very familiar with telehealth and telemedicine. We just written a few papers at Brookings in the last couple of years about this. My first telehealth demonstration was in Anchorage, Alaska in the late 2000s, early 2000s. It was actually really interesting. It was my first time to Alaska, and I did not know in the winter it remained entirely dark. And in the summer it was entirely light. So I got off an airplane, I have to tell this story, and I was getting ready to go to the gala. So I had landed and I was like, oh, I'll take an hour nap before the gala. Well, I woke up dressed and pretty and ready to go, and it was 3 o'clock in the morning. The gala had already passed. So I tell my friends it was beautiful, but I had to remember the way that it actually worked there, right? Make a long story short, I actually saw a good friend of mine, Karen Rubin, who's at the University of Virginia, showed us back in the early 2000s a telehealth demonstration. And it was so fascinating because here we were in Anchorage, and they were doing dermatological interventions for young kids. We were able to see how telehealth and telemedicine worked. That ability to connect remotely on health was so empowering for me. Because I remember, and this is in my book, when I was in Chicago, I was working with a young lady. We both had kids the same age who were afflicted by asthma. She had to go to the emergency room, take off of work, lost her job trillions of times because of the fact that her child went into disruptive shock with the respiratory disease. Me, on the other hand, same child, same age, same sex, same age, could go, take off, go to the local primary care doctor, secondary care doctor. My child grew out of asthma, hers didn't. And this was before telehealth. And so when I got to see the demonstration in Alaska, I thought about that woman and what would have happened if she had the ability to do that. You fast forward to today, these stats are very promising. We see among people of color a high rate of usage of telehealth services, and we see it among people who are over 65, which we're going to talk about, which is not necessarily always the case. Just to wrap up so that we can jump into questions, for me, this is a pivotal time in telehealth and digital health. One, because we're now seeing limited use of technology for patients, particularly medically underserved patients, delays and prolongs chronic disease. When I was at the Joint Center, we were looking at SMS texting, if you all remember that campaign, and now we had email next, and now we're seeing AI who can do reminders and diagnosis, connect you to doctors, and telehealth, which provides you the ability to see a doctor in real time. To me, when you don't have that and you already have a health disparity, in addition to a chronic disease, you're behind the 8 ball. And I think that's a really important conversation to have, and hopefully we can pick up what the commissioner was talking about. Persistent health and care inequities are often due to inconsistent communication with patients. Let me tell you why that's important. Among African Americans and Latinos, trust is a big issue. I'm a sociologist. I know that firsthand from the research that I do. When you do not trust your practitioner, and how many of you in this room as patient advocates have heard people say, no, baby, I'm not going to the emergency room. I'm not going to that doctor. No, I'm just going to figure out how to tough this out myself. No, I can't afford that. That bill was too high. That is a reality that we continue to see. And the other thing I would say, when we do not deploy digital technology, telehealth, telemedicine in innovative ways, people are missing opportunities for innovative care. The young lady that I work with, her child probably would have been okay if she had a primary care doctor, but she would have been okay, and she would have had a job if she had the flexibility to not take 2 buses to get to Walter Reed just to get the care, or to spend the evening in the emergency room to take off of work the next day. That's a real experience that has partly come from our healthcare system. And then I think there's a long road to trust, again, like I said, to the medically impacted and vulnerable populations, particularly at a time, and I'll end here, for real. I'm like a Black Baptist preacher. You get me going, I'm not stopping on this stuff. With all of the pandemic emergencies beginning to ravel up, we have to question what that's going to look like. And so we recently at Brookings put together a paper that we entitled Health Equity, Care Equity, and Digital Equity, because we think that they're really triage opportunities to bring these worlds together. After doing this for so many years, Congress is trying to pass legislation, figure out medical inoperability, licensure. There's all that going on in Congress. States who are de facto health regulators are trying to figure out what's reimbursable, right? Doctors are trying to figure out, well, what should we charge now that this inflated volume of people we had during COVID may go down? Should we continue it? Should we not? Patient advocates, because I get a chance to talk to many people across the country, are saying, but we don't even have broadband. So you're asking us to use this, and we don't even have the tools that we need to do what we have to do, particularly in community health clinics. And patients are saying, I know I have the ability, but no one told me how to use it. And I'm getting thrown the opportunity to do a visit telehealth, and I want my blood pressure taken. So you have this patient confusion. And so hopefully we'll talk a lot about that. Just to give a plug of my book, I spent a lot of time talking about people in this book. That's why it's called Digitally Invisible. And they're not just the people I showed in that prior slide. They're actually people who live in rural America, like Garrett County, Maryland, who have to drive 3 hours to get to the closest health facility. And oftentimes the patient advocate drives 3 hours, but because they can't get technology on the spot to book the client, they've got to go back to the office and come back in 2 weeks. Garrett County had the highest opioid addiction rate, as well as some of the highest health disparities, largely due to the topography. I've seen people across the country, because I did a tour leading up to my book, and it makes me sad, because like I said, I'm 21. I've been doing this for 3 decades. And I'm also a person who has medically impacted family members. And I'm one that sees the work that all of you do at your large associations and individual community organizations. Because healthcare is tricky. And when you throw in technology, it just becomes trickier. And so that's who I am. Hopefully we'll have more questions. I save you some time. I'm like, again, like a preacher. My pastor always says, I'm about to end, I'm about to end. And it never happens. But thank you again for having me.
Thank you. So I do have a couple of questions.
Oh.
I have some questions to start off with, but we would love to get questions from the audience. We really would like this to be a discussion. with everybody, so feel free to jump in. So the first is, how can patients in the patient advocacy community lead the way to make sure that those living with chronic diseases and disabilities are at the forefront of new regulations and technological developments that affect them?
Yeah, no, that's a great question. In fact, I want to pick up on what the commissioner said about AI and generative AI. And so I think all of us are beginning to see the impact of artificial intelligence systems on our work, right? I see it, academics are seeing it. You know, AI is created in many respects to be a repetitive function of things that we do. But generative AI, which is interesting, is actually backwards looking, because the data that it trains itself on is historic data. It's not data that's forward thinking. So I want people to know your generative data has eyes in the back of their head, I once heard. And I told this woman I'm going to use it every time I talk about it, because it's an easy way to understand it. With that being the case, we do suffer this digital divide, like I've already mentioned, where people don't understand these technologies. And they don't often understand that these technologies are being used without their agency, primarily because we, as practitioners, often use these for efficiency. So there's a conflict that exists with technology, and particularly among impacted communities, it's important for us to also make sure that these technologies represent their lived experiences. So oftentimes, technology is not developed by people from the disability community. It's not developed by people who represent medically marginalized people. A great example in AI was a couple years ago, a healthcare institution wanted to screen out people who were eligible for a program for the chronically ill. So they put it in the hands of developers, and those technologists thought they were creating a really great artificial intelligence model. Well, they trained it on data that measured how much people pay into hospitalization. And when you use that as a metric, who gets kicked out? So the majority of people who would have been eligible for the program but were kicked out were Black patients. That was a front page newspaper. It's very public. You can find it online. But for me, for patient advocates who are trying to deal with these different technologies, you know, the thing that I always suggest is you have to learn about them, right? And you have to know them on various layers. We're not expecting people to be technologists, right? I don't want to go back to school. I have a PhD in data science. But what we do need to know is, how do we exercise agency over these technologies? How do we demand that, one, when we're buying them, we know what they can do and their limitations, but more so that when we're bringing them to patients, they know that they're in operation. And that's a big deal, particularly for those who are trying to be like my mother, use these technologies, but are not clear about how their data is being collected, right? Where are these visits being stored? What impact does this visit have on other things, right? Same thing with our digital health kits. Where does this data go? Is it deleted? Does it make determinations around my health insurance? Does it help me as a patient understand the services that now I'm receiving in the mail? To me, it's a sense that we think we have a disaggregated technological ecosystem, but we don't. And I think many of us in this room would not know how these technologies operate. And so it's hard for us, particularly when we're dealing with other things that are critical, like keeping people alive and healthy. How do we start dealing with these technologies that pretty much take on their own lives?
So I have a question.
Yes.
At the Alliance for Aging Research, we deal with the aging population over 65. They have a lot of comorbidities. They have a lot of, I shouldn't say a lot, but they have some limitations,
Yes.
sometimes hearing, vision, different
Yes.
ways that they interact with technology. If you're going to go do a meeting,
Yes.
right? How do you get them to the point where they're comfortable enough on the technology to even have that meeting with that doctor, right? Are you talking extra support staff,
Right.
fewer support staff? If we're trying to get rid of, FTEs, how does that balance out, right?
Yeah.
Are companies going to be willing to pursue that if it means, no, actually you need more hand-holding, less hand-holding?
Yeah. No, I think that's a great question, and that's a great question to ask right now. I'll answer it as a policymaker, then I'll answer it as someone who cares about that issue like yourself. I mean, as a policymaker, we're sitting on the largest down payment in broadband infrastructure, right? So President Biden, Vice President Harris have put together the bipartisan infrastructure bill. $65 billion are in that bill to allow for more deployment of universal networks in rural and urban areas. But there's also a caveat in that bill to create what's called digital navigators, which are people who are going to go to folks' homes and help them take advantage of these applications that run off the internet. There's a lot of money in those programs. How many people even heard of the Infrastructure Investment Act in terms of bipartisan bill, see? and the digital navigators, right? Not a lot. We've got to do more education on that, right? Because that will help. One of the areas that I am advocating for myself is what's called a digital service corps, which would be the place that would supplement our patient advocates on the ground to allow them to get like a Corporation for National Service grant, where they can go into communities, they can be part of communities, which I think also helps with the trust issue. But that's only one part of it, like you said. I mean, seniors have been way exploited in every aspect of our economy. And when it comes to healthcare, we want them to use things. I'll give you another story. A couple of years ago, the AARP tried to put Alexa devices in the homes of seniors who lived in assisted living, senior subsidized housing. So they put one in Northwest DC, I think it was, and they put one in Baltimore. So one was an Eastern European building primarily, and the other one was African American building. So they said, okay, we're gonna give you these Alexas a few years ago, and we're gonna let you use those so you can remember your appointments, you can ask questions of Alexa, you can combat loneliness. Well, the Alexa that was in the Eastern European housing, no one used it because Alexa did not understand them because of their accents. And so the cultural experience was completely devoid in the design of the system. The African Americans in Baltimore didn't use it because they didn't want nobody talking to them in their house that they didn't know. So they basically would not turn on the Alexa, which is like so true with people. When I was doing digital technology, African American families wouldn't even turn on their PCs or their computer monitors. They were like, no, honey, I'm not putting that on. I'd come back 2 weeks later to have a coffee cup on it, talking about a sheet covered up, right? Because of the trust factor. And so there are technologies that we can use, and I'm sure many of us have done this with our elderly parents, right? Mom, put this on your phone, do this. It is going to require a one-on-one conversation, unfortunately. You know, humans are in charge of technology. It's not the other way around. And so I think in a very intimate space like healthcare, we're gonna have to find ways to break through some of these infrastructure investments. And there's also, adjacent to this, a digital equity fund, which is actually allowing for these type of innovative projects. You know, I'm more than happy to share that information with Omar so everybody has ideas. This money is coming and it's gonna be spent. It's the biggest down payment in connectivity in American history. But then there's also the Affordable Connectivity Program. For your folks that don't have access and need digital literacy, there is a grant program that offers subsidies, $30 a month towards their broadband and $100 for device. My point is we've gotta break the divide. We've gotta make sure people have trusted ambassadors and champions. And I think third, we've gotta make sure that there's no breach of trust with our communities that are impacted, so that if we get them on there, a person is still not feeling like, you know, you put me on here and now I'm getting all this stuff in the mail. It's a hard question, but it is one I have to say. Our stats tell us when people are over 85, they would like to age in place, but they can't because they don't have the technologies. I just visited my own father-in-law in a nursing home.
So we have a question.
Oh.
Hi, thank you so much for this conversation. My name is Dr. Marissa Robinson, and I'm from the Office of Infectious Disease and HIV/AIDS Policy at Health and Human Services. So I wanted to ask a question. Obviously, in the federal health space and a lot of different spaces, we were all teleworking and at home for a number of years, and now slowly but surely we're starting to get back into the office. There's a lot of conversations about telework and going back into the office and how productive we were, not having to commute, not having to be in person, and being able to have digital spaces in webinars and other meetings that we were able to take. So what is your perspective about us having to go back physically into the office? We're hearing a lot about, we need to be back in the office, and some people are arguing that we have the, you know, technologies and the advancements to not actually have to go in person.
So that's a hard question, probably another panel. And I don't want to get in trouble too, because I have some opinions about it. So I think, I'll put it actually like this, because I think my telework friends would want me to define it this way. So telework did have some benefits, right? It had benefits to mental health. It had huge benefits to people with children, people with elderly parents, people who were in the market of just not feeling motivated because of the environmental factors. And that's a healthcare issue, right? When you have people who are dealing with the stresses of maintaining a family, having to commute, et cetera. So I do think that there were benefits. I mean, I can tell you personally, for me, there was. I was a person that was on the road probably every other week, and it gave me an opportunity to reconnect with my own family and take care of my own health. It was also a time of isolation and loneliness in terms of the rate of health disease, particularly among women of color and various chronic disease and cancer, in fact. A lot of people got sick because they didn't go to the doctor. And so there was this thing about, I think there was an inherent relationship between being home but not taking care of yourself. Because there were folks that were home that worked longer than usual hours, saying, I'm putting in the work, I'm being productive, but they weren't necessarily taking care of their basic needs mentally and physically. And so I saw that. In fact, it's personal, to me, because a lot of women that I know, professionals, regardless of color, didn't go to the doctor, and now dealing with late stages of various ailments. I think the third thing, though, that happens when people don't work is that they affect the economic environment around them. And so the spiral effect of us not working is that our local restaurants and businesses aren't there. Our office spaces. One of my colleagues at Brookings just wrote a really interesting piece on conversion of commercial spaces because of vacancies. I share that to say, I think it's up to companies to realize just a couple of things. Particularly, one, that productivity has different definitions for various people. And if you have people, like I telework, but I'm a researcher, I'm a think tank person, so I can probably write anything from wherever I sit. But based on your position, based on your supervisory capacities, based on what you're trying to accomplish in your work environment, companies have to make those decisions, right? I think companies shouldn't be command and control about it. I think they should ask their employees. And then I also think that when we talk about telework, we also have to consider some roles needed to go in. And that also had impacts, particularly on health. A lot of the folks that died during COVID that had a lot of comorbidities were frontline workers. And those frontline workers not only had comorbidities, but they lived in densified housing. They lived in spaces where multiple people were in the home. They lived in areas with limited access to health care. And so I'm hoping that, everybody's like, well, COVID is over, we can move on. It's really not. It's changed the normalcy as we know it. And for all of you here, based on where you sit, it's changed the interpretation of what you work on now too. Because it's not just the physical, but it's also the mental and the well-being has become a big conversation going forward.
Thank you.
Hi, thank you so much for every piece of information that you just shared, because I learned so much, and I'm looking for your book online. There's no e-version of it.
No, it's coming out January 2024.
Oh, that's why I can't find it. That's why I can't find it.
It will be on Amazon, at your
why
airport.
can't I find it? How is the book on the digital divide? Not digitally accessible, but now I know. Now I know. Okay, didn't want to say that, but okay, that's good to know. So I'm Debbie Drell. I'm the Senior Director of Membership at the National Organization for Rare Disorders. I'm also a second-generation daughter of Mexican immigrants. 60 million Americans are Latino, and a big proportion of them are immigrants, and immigrants are the fastest growing population. NORD is doing work with Hispanohablantes and Latinos listening sessions to learn, and something I learned that I want to ask you is the distrust of data collection for fear of deportation, and how that impacts diagnosis, because there's already delay in diagnosis for people of color. And then when you add language barriers, but then you talk about this country that is right now scapegoating Latino immigrants, and this whole fear that the government is going to capture your information. And if you're having to now go on your phone for a telehealth appointment and you're putting information in there, what are your thoughts on how we bridge that divide? Thank you.
Oh, I love that question. I love it. So in my book, I actually visited a school in West Phoenix, Arizona, in Maricopa County. And I have a chapter on education and digital divide. And the school in Maricopa County, the principal is fantastic, right? He was very we're moving kids from from surviving to thriving. We're a lead school, boom, boom, boom. And 90% of the kids plus elementary school all had cell phones, okay? And so I was like, this is new, right? Every kid elementary got a cell phone. I can't believe it. And I asked the couple of teachers, I said, everybody has cell phones, why aren't you just using that, getting people connected? And he said, well, there's two problems. They have cell phones for fear of deportation of their parents. So every kid carries a phone so they can be contacted in case somebody's not home. That was the first thing. And that just blew me away. And then when it came to having the cell phone, but signing up for like free and reduced price lunch, other programs, they wouldn't do it. So the cell phone was the communication network. And if you know anything about Maricopa County, you know, when I did my research, they were coming out of the time of huge immigration deportations, illegal deportations. It made sense as a survival mechanism. What's interesting is after I did that visit, I went to the local library and I met a woman named Frances. She's an African-American woman. And she was at the library with her son, and she had a smartphone, and I was one of those people like, hi, excuse me, can I talk to you about your internet access? I know you don't know me, I'm not the police, I'm not a case manager, that was just a true story. And I got to talking with her, and because she had a smartphone, she was getting treatment for stage 4 cancer that she would have never known about had she not been at the public library looking up something about this lump. And it turns out her doctor put it, you know, she went to see a doctor, but she's used her phone to get her updated records. I share that because it's a catch-22, right? That chapter for me was like, these kids are walking around with cell phones, but they don't want the reduced price lunch. They can't sign up for the internet programs. You know, the parents don't come into the school because of this fear. And this woman is sitting at the public library, finding out in a public terminal in a library that she has cancer, now hoping her cell phone stays on so she can look at these records and keep up with her appointments. It is such a fear that I think people have that's a distrust of technology. And I think that's why we have to get agency over emerging technologies as practitioners. We cannot let these technologies continue to exist in labs and get deployed on our folks that we care about and then used in ways that it criminalizes them, manipulates them, exploits them, takes their data and uses it for other purposes. This country, we don't have a federal privacy standard, so it's always possible that anything that you put on the internet, if it's here and not Europe, is going to be used for ways that are not necessarily purpose for your intention. And for our immigrant communities, that is a fear. Their information has value to the extent that it can be mined and harnessed for very egregious accounts. And you know, in my work, I care about that stuff. You know, I'm working on a project right now, facial recognition technology and custom border control, things like that. It's important for us to keep those questions. But I can't do it by myself. We need more people like yourselves to contribute to this dialogue and conversation.
Were you there? Sorry for that.
Hello, Jessica Kennedy. I use she, her pronouns from Mental Health America. And we had a chance to visit one of our rural affiliates last year, and we expected, you know, telehealth was going to be a huge barrier, which it was both a barrier and an opportunity. Yes, yeah. Because what they'd found is they were able to use the counselor's office at the schools to let the students use telehealth because they knew they had broadband at the school. So I was curious, you know, in addition to libraries as one, you know, anchor institution that can provide that, what are the opportunities to use anchor institutions like post offices, pharmacies, things that do exist in every community to potentially be hubs for, you know, people who don't have their own access to get telehealth services?
Oh, definitely, definitely. Churches, faith-based organizations played a role, as you saw with COVID, with vaccination. They played a role during the digital divide. Right? Churches were opening up their basements, doing tutoring, helping kids. Small businesses, I've seen restaurants convert themselves into Wi-Fi hotspots. Community health clinics, I've actually seen those folks open up their doors to do virtual appointments for seniors and bring them through. Community technology centers. In Cleveland, Ohio, Wanda Davis runs a technology center for senior citizens and brings them in for all types of activities and raising their awareness. Unfortunately, in this country, we define anchor institutions as schools and libraries primarily. And in the money I just spoke about, non-traditional anchor institutions actually play a big role, but they may not necessarily get all the funding that they need to do that. My hope is that we'll change that, right? And we'll see more non-traditional anchor institutions get money through digital equity, funds that are available through the federal government. But we also have, and I just want to put this out there, through the Federal Communications Commission, we have opportunities to get money through their Connect healthcare programs. So there's a variety of funds, particularly in rural America, to fund some anchor institutions going forward. But we have to also convince those anchor institutions that they can open their doors beyond a certain time and allow other people in.
George Gondo, Director of Patient-Centered Research, National Psoriasis Foundation. Loved what you're saying. One of the things I'm always concerned about is that we, as a society, are at a sort of an inflection point where it seems like we're leaving behind a whole just mass populations, right? And as I hear you talk so eloquently about the digital divide and these realities that are out there, and then we think about the oncoming AI, ChatGPT, and algorithms that are slowly kind of really becoming a prominent place in our lives, especially in healthcare, what risks do we have of those enhancing that divide, and how can we prevent them? Because this is, I think, a real inflection point to start thinking about that.
Yeah, that's why I call my book Digitally Invisible, man. I mean, at the end of the day, technology it can help us, right? I mean, when I think about telehealth and what we saw during COVID, I'm actually encouraged, right? Because there were a lot of people who weren't getting real-time care that we were able to put them on their phones, even if it was not synchronous, right? Even if they came back later. There were a lot of people who got on telehealth that did not show their homes. You know, they didn't even turn on their cameras, particularly people of color, but they got on. And so for me, that was promising in terms of the particular use case of technology when it worked. You know, it didn't work for school-age kids as well as we thought, but it's something that's working now because we're learning that we can tailor educational modules to kids that may be learning impacted. With that being the case, there's no silver bullet with technology. The challenge is that the digitally invisible are no longer poor. They're no longer immigrants. They're no longer people of color. They're no longer older. And they're no longer people who are foreign-born or rural. They're actually everyday people who, wherever they live or choose to live, they can't get access. People who want to live in rural but can't take advantage of technology or telehealth because they don't have any connectivity. So we're in a quagmire, we're in a place where we haven't solved this issue, but yet we're enhancing technology and overlaying more of the cognitive intelligence of it, and it's going to create a wider divide. Generative AI, for example, we talk about chat box technology. There is an assumption of linguistic ability. It's very textual, which means you have to know how to read, which means you have to be knowledgeable that the computer can actually input and output things in ways that make sense to you.
Well, you have to interpret things the same
You
way,
have to
right? So
interpret.
we had that issue with the Hispanic immigrant community. We
Yes.
found the word trial is not a good word for them,
That's
right?
right.
They
That's right.
right? That does not mean good things. And so explaining a clinical trial, right, and trying to have that communication and have it work is challenging when you're a person, let alone AI.
That's what I'm thinking, right? And we don't have the people who look like the lived experiences or have the lived experiences of groups making these products. These are very elite circles of folks making these products and services that are making and applying them on communities. And it's not just race-based. There are examples of new technologies that are testing out thresholds of pain for women being tested on men. You know, it's one of those things that I find in my experience as a policymaker and a civilian, right, is I love technology. I mean, I'm that person that's the first in line with the technology, I'm not gonna lie. But I can't keep up with it. My kid's better than myself. But more importantly, I'm afraid of it. And I'm not afraid of it because of the technological incompetence of technologists, right? I'm afraid of it because it's just it's unhinged. And the more that we rest on technology, it almost reminds, I used to say a couple years ago when I was talking about AI, that I used to watch the Jetsons when I came home from school, right? I would watch the Jetsons and, you know, George Jetson would be flying around with his autonomous car and, you know, Betty would be looking in the mirror and her hair would be perfect, you know, things like that. And I was like a kid thinking, this will never happen. Well, it did, right? And it's beyond my wildest imagination because it's not even the Jetsons anymore. You know, we're actually seeing robotics and augmented and virtual reality, and we're seeing it in healthcare in ways that make sense because it allows us as clinicians to really interpret experiences for patients, but it also comes without the auditing and the checking and the validity that bias is not embedded in those models.
Do we have another question?
Yeah.
Ashley White, Amputee Coalition. We recently conducted a prevalence study looking at individuals, the prevalence of individuals' limb loss and limb difference in the United States. At the top of this session, you talked about missing information and sort of how we can look backwards at the data we have to develop what's going forward. And I think one of the strongest challenges for us is looking at what's not there in the data right now that's being used by payers to decide how they're going to pay for things. 41% of the claims that we looked at did not have race identified in them.
No.
And so, I mean, even our most basic systems of digital data collection are failing. How can we expect the next generation of technology to get it right?
Right. So that's a hard question, and I'll tell you why. So most technological systems do not collect demographic information, right? So they're not bound by HIPAA or civil rights laws. This is a true fact, right? So they tend to do, if I give an AI lesson, they tend to use what Dr. Michael Kearns and Josh Kroll call, it's not Kroll, but somebody else, but Dr. Kearns, I know for a fact. But they tend to use inferential data. And that means is they infer based on your digital footprint who you might be. So I give this example. I love shopping, right? And so you see me in this blue dress. If you catch me next year on a lot of Zooms, I'm probably wearing that dress, right? Because blue is my color when I am online. And so I found myself shopping for a lot of blue dresses, right? Over the course of the pandemic and probably my life, because I love me some pastel colors. I'm from New York, and when I moved to the South, you all wear red, strawberry, peach, and I'm down with it, right? In terms of colors. But when I'm on the internet buying blue dresses, I might get a recommendation for a shoe because the internet has picked up that I buy blue dresses. Then I might go in there and I'm checking my bank account because I want to make sure I have enough money for my blue dress. And the internet is seeing, well, she's always going on her bank. So she's somebody who is money conscious or not. Then the internet may see that I have a daughter. I buy her stuff. Over time, LaTanya Sweeney at Harvard suggests that it develops a digital profile of inferences that then suggests that this might be a person who loves blue dresses, that has children, who's always checking their bank account. And by the way, she has a name, in this case it's a true story, that may sound, I mean, I'm Nicole Lee. Sometimes people think I'm Asian. They don't often think I'm a black woman. It's all good because I love the fact that I can be ambiguous, right? But at the end of the day, they start to compile those. So there's research that suggests if your name is Julio, Juan, Shawanda, the internet picks up on your name. And then over time, you'll be marketed higher interest credit card offerings. And this has actually happened. So race is not necessarily needed in this new inferential data economy. It is basically, we went from maybe 100,000 to trillions of variables on every single person in this room. And the computer mines that data enough to come up with what they think is a predictive outcome of how you're going to shop. There's even facial recognition technologies that can look at your face without knowing your race and determine sickness. There are things like that in technology, to your point. It's the missing data, but it's also the data that I like to consider the deliberately missed data. The data that doesn't get you in trouble. The data that doesn't allow for causal relationships, for you to actually find yourself in litigation. It's the same as the example I gave earlier about the program with chronic disease. We all know historically that people of color have higher rates of chronic illness, but yet that was not a determinant factor to get into this program. And so things like that, I think over time, it's going to be missing data, extracted data, deliberately denied or looked at data, and what my other dear friend Renee Cummings at UVA talks about, which is traumatized data, which is data that also co-affiliates you based on the history of certain scenarios and circumstances. So from your community, what does that say about, again, healthcare, life chances, eligibility for programs? We've just kind of moved to society that no longer deals a lot with its discrete metrics, but more inferences. And that's the, kind of going back to the earlier question, that's where we are, I think, with technology. The extent to which we've developed over time in our history and in our cultures here in the United States and abroad, very discrete measures of how we figure out whether something is fair or unfair, responsible and not, equitable and not, and those lines become really blurred the more that this technology is sort of commercialized and launched in ways to suggest that it's fair. It's like when I was starting my research, I was suggested to go to like one of those like search engine polling tools. So I was like, oh, great, this is great, until I realized, like the young lady said, well, if I'm looking at the digital divide, no one's gonna be on these things, and they're definitely not gonna be behind the paywall, right? So we've got to, as I think, and the commissioner said it so well, when we're dealing with these use cases like healthcare, what's our interrogation of these models? How do we think about the mitigation of the various biases that may show up in these models? How do we connect these models to real circumstances of care equity and health equity? How do they show up with environmental factors? How do we develop an IRB in technology that allows us to carefully manage human subjects? Don't bother me when I'm buying my blue dresses, but worry about me if there's something there that triggers a response that I need to actually, that's a use case that's of critical importance.
So I hate to interrupt you.
No!
I absolutely hate to interrupt you, but we are out of time.
No, it's okay.
If you want to finish up.
No, I would say thank you. I mean, we started, this blows my mind because I've been doing this again since I was 21. And we started with these conversations about a digital divide that was very binary, right? Who's online, who's not, who has access, who doesn't, who has a device. And now we're actually finding that this technology that we thought was binary is very complicated, very multi-layered, and it not only impacts the traditional technological framework that we're mostly used to, it impacts the quality of the life of people, and it impacts us in places that matter. They differentiate well-being, mortality, they differentiate those things. And so I'm so happy that I had an opportunity to talk about this. As a person who was in telehealth watching a dermatological experiment at that time, we've come a long way, but the road is not over. And the task before all of you and your associations has just become more complicated. So if I could just leave you with these words, pay attention. Pay attention. Because the people that we care about every day are the people that will continue to be the subjects of these technologies that we're deploying on them. So thank you very much. I'm humbled. Thank you. You were awesome. Oh, you're amazing. I was like, wow, that was a...
And we have a break for about 10 minutes, so we'll reconvene at 11 a.m.